Welcome back to the channel. Today we're going to discuss atrial fibrillation. It's by far the most commonly presented arrhythmia, with about 5 to 10% of patients above 75 years old having it. We'll start by discussing the different types of AF, where they really only fall into two groups: paroxysmal, where there's episodes of normal rhythm in between, and persistent AF, where there's sustained atrial fibrillation in which cardioversion to sinus rhythm isn't appropriate for whatever reason. If a patient, however, is displaying symptoms, they classically would be short of breath, with palpitations, dizziness, and possibly even chest pain. On examination, classically these patients will have an irregular pulse. Much of the treatment of AF is dependent on whether the patient should be rate controlled or rhythm controlled. Every patient should be treated on a case-by-case basis, but typically rate control is favoured in patients over 65 or with a history of ischemic heart disease, whereas rhythm control tends to be favoured in younger patients or symptomatic patients with AF, or if there's a history of heart failure. When discussing rate control, first-line options are usually to maintain people in rate-controlled AF with beta blockers, rate-limiting calcium channel blockers, or digoxin. When discussing maintenance of sinus rhythm, or to keep people in sinus rhythm and not flip into AF, first-line treatments include sotalol, amiodarone, and flecainide. There is, however, a surgical option for some patients, where NICE recommend the use of catheter ablation therapy in those who want to avoid arrhythmogenic medications. The aim here is to destroy any irregular electrical pathways, but the key here is that anticoagulation is used for at least 4 weeks prior to the procedure, given the risk of clot formation. If, however, in the acute setting, a patient is physiologically compromised because of symptomatic AF, then cardioversion, either electrical or medical, should be considered. If a patient presents within 48 hours of symptoms, then cardioversion either electrically with DC cardioversion or medically with amiodarone are the choices. The latter is particularly useful in patients with some element of structural heart disease. If, however, the onset was over 48 hours or of an uncertain time, there's a theoretical risk of clot formation and thus risk of stroke, and therefore the patient would need to be anticoagulated for at least 3 weeks prior to electric DC cardioversion. An alternative to this would be for patients to have a transesophageal echo to rule out any atrial thrombi. We also need to go over anticoagulation, which is all dependent on scoring systems. CHASBLED is a scoring formula where the risk of developing a stroke because of AF is calculated by the following: congestive cardiac failure, hypertension, age above 75 or age above 65, diabetes, stroke or TIA, vascular disease, or being female, where all of the above score 1 point, where age is really the only one that gives you 2 points over the age of 75. If a patient scores 0, then no anticoagulation should be considered. If a patient scores 1, only if they're male consider anticoagulation, and if it's 2 or more, consider anticoagulation. Confusingly, there is also a HASBLED scoring system, which helps identify the risk-benefit ratio of anticoagulation. Essentially, the higher the HASBLED, the higher the chance of risk of bleeding, including intracranial hemorrhage. Each point accounts for 1, where a total of 3 is deemed as severe. The points included are hypertension, abnormal renal or liver function, stroke, bleeding history, labile INRs, elderly patients over 65, or drug and alcohol use. And that's that. I hope you enjoyed the video and have a greater understanding of AF and its management. Please let me know if you have any suggestions in the comments below, and be sure to like and subscribe. We've got a growing Facebook and Instagram page as well, so be sure to head over there too. But otherwise, I'll see you in the next video.